All right, hello and welcome everyone to tonight's webinar. I'm thrilled to be spending this February 29th Rare Disease Day with all of the zebras tuning in. I'm sporting my stripes in honor of the more than 30 million Americans living with a rare disease, including those with one of the nearly 500 types of primary immunodeficiency. This evening, I'm excited to bring you the next session in the Immunodeficiency Foundation's Ask the Expert series. You'll hear a brief presentation followed by a more in-depth Q&A opportunity. Tonight's topic is primary immunodeficiency and fatigue, led by Dr. Joud Hajjar. We will learn more about the correlation between PI and fatigue and how to manage this symptom in your day-to-day life. My name is Alyssa Creamer, and I'm the Senior Director of Education and Community Services at the Immunodeficiency Foundation. On behalf of everyone at IDF, we thank you for tuning in to this virtual event. We created this webinar series knowing that life with a PI can be complex. Our experts could talk for hours, but by focusing on our audience's ability to ask questions, we create a learning environment where our community members can guide us on what's most critically needed in their journey. And those are the items we'll prioritize tonight in our time together. Before we get started, I'd like to share a few items to keep in mind for our program. This evening, we are using the Zoom webinar feature, and attendees should be able to see the slides and hear the presenter and host speak. Attendees will not be able to activate their video camera or microphone, and that means all your questions need to be typed into the Q&A box on the control panel of your screen. All questions will be read aloud and anonymously on your behalf. As you begin to brainstorm questions, please keep in mind that questions should be relevant to today's topic. Questions that don't pertain to today's area of focus should instead be submitted to our Ask IDF platform. More information will be provided at the end of tonight's program on how to do that. Additionally, questions should not contain any personal health information, which includes things like your medical history or your lab results. We also ask that no questions be submitted that name specific brands of medication, providers, or healthcare institutions. So that we can answer as many of your questions as we can, our team will monitor the Q&A for similar questions, so we might not read yours aloud word for word. And then lastly, to keep the conversation focused on PI-related fatigue, Dr. Hajjar has asked that you not ask questions about Epstein-Barr-related fatigue, fibromyalgia, and chronic Lyme disease. A brief disclaimer. Please remember the information presented during this meeting is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified healthcare provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational event. This webinar is made possible by our wonderful sponsors. It's due to their partnership and contributions that we can provide programs like this to the PI community. Please join me in thanking today's sponsors. And now I'm pleased to introduce our presenter for today. Dr. Joud Hajjar is an associate professor of immunology, allergy, and rheumatology at Baylor College of Medicine. She is also the service chief of adult allergy and immunology at Texas Children's Hospital. Hajjar is a long-standing member of IDF's Medical Advisory Committee and a 2022 IDF Research Grant recipient. She has a robust track record in managing adult patients with inborn errors of immunity, eosinophilic disorders, and mast cell disorders, for which she has received numerous awards. Thank you for joining us, Dr. Hajjar.
It is my pleasure. Thank you so much, Alyssa, for this kind introduction. I'll start by sharing my screen. And if you can just give me a thumbs up if I'm in the right track.
Yep, you're all good. Thanks, Dr. Hajjar.
Absolutely. Well, good evening, everybody. And I'd like to start by thanking the Immunodeficiency Foundation organizers for inviting me to talk to you today. The topic is dear to my heart, PI and fatigue. And before we start, I'd like to just present my disclosures. I did receive grant funding from the Immunodeficiency Foundation that supported some of the research on fatigue and immunodeficiency, for which I'm really grateful for. And I don't believe I have any conflict of interest between any of my fundings and the presentation that I'm going to be doing today. What I hope to do is to focus on three different aspects. The first one is, why do we need to pay attention to fatigue in inborn errors of immunity? And I will be referring to primary immunodeficiency as inborn errors of immunity. This is the term that is now commonly used in the Clinical Immunology Society, and I will use them interchangeably during this presentation. The second aspect that I would like to focus on is what contributes to fatigue in patients with immunodeficiency. And third, I'll spend some time talking about how to manage fatigue in immunodeficiency. But before I start, I always like to provide some definitions so we are all on the same page when we're talking about fatigue. So when we refer to fatigue, there are two broad categories under which fatigue can fall in. There is the physical fatigue, when a person experiences difficulty performing physical activities, and there is mental fatigue or cognitive fatigue. And this is when people experience difficulty in concentrating and carrying out cognitive tasks. And as you can imagine, those can be intertwined. So if somebody is extremely physically fatigued, they may not be able to do very complex cognitive tasks. And also, if somebody is mentally fatigued, they might also feel physically tired. So we'll start by the big question: is all fatigue bad? And the answer is perhaps not. Fatigue is many times can be a physiological adaptive response. So for example, if somebody is overdoing an excessive exercise, so let's say somebody who's not athletic trained and try to run for 2 hours or 3 hours, most of the time they are not able to do that. And if they try to push themselves really hard, their muscles will start to hurt and their body will feel very tired. And for people who don't listen to their body and stop, you might have heard with the words rhabdomyolysis or lactic acidosis, in which means that the muscles break down and the body starts to break down the muscles, not using oxygen, and they can get into really lactic acidosis, sometimes renal failure. Their muscles will break down and they can get multi-organ failure. So feeling fatigued in this scenario is the first warning sign that you're overusing your body or overusing your muscle. You need to stop to give it a break. Otherwise, there will be bad consequences. But what we are going to be focused on today is the different kind of fatigue that is pathological, which means that it is not really in response to a significant physical stress. It is not trying to adapt, but rather interfering with the person's ability to function. And that's what is we consider as pathological fatigue, when it starts to interfere in individuals' ability to do what they need to do or what they like to do. And the consequences, as you can imagine, that a person will feel run down. They may not be able to perform their tasks. They can become also cognitively exhausted, not able to function. This will affect students in their schoolwork, people who work, not able to perform their work. It might affect relationships. And it definitely has financial consequences, because if people are feeling too fatigued to go to work or school, that will affect their ability to do a full job and affects the income. And sometimes it affects also the caregivers who are not able to do full work. So it really has major impact on the patients and their caregivers. When I started studying fatigue a while ago, the three major arguments that would come to why should we care about fatigue is, the first is that, like any chronic illness, fatigue is expected in immunodeficiency, so it's not unusual, or it's just kind of part of the disease itself. The second argument would be that fatigue is not life-threatening. People are, probably have bigger problems that they have to worry about, like their lungs, their gut, their infections. So it's just not life-threatening. So fatigue is to be endured, and we should not focus our treatment on fatigue itself, but rather just try to treat the underlying causes. And this is the third argument as well, that if your disease is under control and your infections are under control, your fatigue will automatically improve. I'd like to keep those statements in mind, and we'll go through this presentation and I'll revisit those statements towards the end and see what the research has helped us answer those three statements. So the first question was, is it really true that fatigue is increased in patients with immunodeficiency? And to answer this question, we actually looked at data from the US Immunodeficiency Network. This is a database that is filled by healthcare providers who take care of patients with immunodeficiency. And in this specific survey, there was an intake form in which the healthcare providers check a box whether they think their patients are fatigued or not. And if you look at this figure here on the left, the line is what is considered to be the prevalence of fatigue in general population. So in the US and UK, it's estimated that 3.5% of the general population experience fatigue. And as you see, the vast majority of the diagnoses are way above that threshold. So that indicates, just by looking at the graph, that fatigue has been reported in almost all the immunodeficiency diagnoses that were in the US IDNet, and except for the George, because most of them were children and they usually have a lot of other health issues going on. So perhaps they were not perceived to be fatigued by their healthcare providers. The one diagnosis that stood out was common variable immunodeficiency, with almost 30% of the individuals with CVID were perceived by their healthcare providers to have fatigue. And when we looked at the factors that were associated with fatigue in this database, we found that the individuals with non-infectious complications like having arthritis, lymphadenopathy, splenomegaly, any kind of inflammatory comorbidity was associated with increased prevalence of fatigue in patients with a CVID. And also, when we looked at the immune cell numbers, when we had the data available, we found that the patients who have fatigue had lower numbers of immune cells compared to the ones who were not reported to have fatigue. So this was the first paper that really acknowledged that fatigue is truly increased in patients with immunodeficiency disorders. Multiple papers came after that and specifically looked at fatigue in children, because it was also a myth that children do not experience fatigue because they often are more hyperactive and are often considered to have more energy than adults in general. But when specifically looked, this paper did report that children with immunodeficiency do experience severe fatigue. It's very common in those children, and it has been associated with poor quality of life in those children. And this paper appropriately looked at the impact of fatigue on school absences or work absences in teenagers, and they did find an association between having fatigue in children and their ability to attend school or attend work. In this specific paper, they did not have the same findings that we find in the US IDNet, that patients who have more disease activity or more comorbidities had more fatigue, but different papers have different designs and different power. They did, however, note that there was a significant amount of children who have additional outpatients visit, daycare visits, hospitalizations. They needed immune suppression. So there was more disease burden at the end of the day in those children who had fatigue. We also looked at the relationship between fatigue and quality of life directly, and this work was led by Dr. Nick Ryder when he was at Baylor College of Medicine, and those data were from the Immunodeficiency Foundation. So perhaps many of you have contributed to this data through the survey that was distributed by the Immunodeficiency Foundation. And in this particular survey, it was noted that fatigue was associated with worse quality of life. So the people who contributed to the survey and reported that they have fatigue also have answered the questions on quality of life, and they had lower scores compared to the ones who did not have fatigue. So why does this matter? Because quality of life has been better studied in immunodeficiency and in CVID, and there have been a link between having a worse quality of life and having increased risk of death. And there was a study that was done by Dr. Isabella Quinti's group in Italy that have followed patients over a period of over 10 years. Those patients had CVID specifically. They have asked them questions about their quality of life at the beginning, in the middle, and towards the end. And they have looked at the patients who have worse quality of life scores, and they found that the chances that those patients have died after the follow-up period were higher than the ones who reported better quality of life at the beginning of the study. And through modeling some biostatistical analysis, they predicted that if you could improve the quality of life by 1 point, you could decrease the risk of death by 2 to 3%. In a way to try to highlight that having fatigue and having poor quality of life directly relates to outcomes and life expectancy in patients with CVID. So we're always interested in factors that can predict having fatigue or contribute to fatigue. And the studies that, or the data that I'm going to share with you do not come from one study, but rather stemmed from multiple studies that looked at fatigue in CVID and other immune deficiency disorders. So multiple papers refer that females usually report higher prevalence of fatigue compared to males. The individuals who experience mental health disorders, whether it's anxiety, depression, any kind of mental health condition, tend to report fatigue as well. Having an underlying malignancy increases the risk of fatigue. And of course, there is cancer-related fatigue literature that is very vast. And some of the data that I will share with you towards the end for treatment is borrowed from cancer-related fatigue. Consistently across multiple papers, having end organ damage from the underlying immunodeficiency, especially the non-infectious complications, whether it affects the lungs, the gut, or having enlarged spleen or having arthritis, has been associated with increased risk of fatigue. We also looked at the Immune Deficiency Foundation survey data, and we found that specifically in CVID, from our patients, who some of them are in the audience, we noted the same thing. The patients who reported fatigue had more lung disease, GI disease, neurological disease. They have impact in their ability to be physically active. They have impact on their vision. They have even more problems in their kidney and their liver, indicating that there is an association between having fatigue and having more disease burden in general. And finally, there were a lot of studies that pointed towards wear of effect, but not specifically studied it. So we looked at one more time at the Immune Deficiency Foundation data, and we asked specific question: is fatigue associated with one route of immunoglobulin administration versus the other? And in this specific study, we found that people who were on IVIG reported more fatigue compared to the ones who were on subcutaneous immunoglobulins. And particularly, there was a chronological relationship between the time of the end of the infusion and the time that the patients received fatigue. So let's say, for example, somebody was on a 28-day cycle of immunoglobulin. They reported that they start feeling fatigue on day 21, 22, so the last week of the infusion. And we refer to this as the wear-off effect. I would say that those results were not always true in other studies. And there is also a component that some people experience fatigue on the day of the infusion or a couple of days after the infusion. So we do look at the infusion route, and if somebody is experiencing a lot of fatigue towards the end of the infusion, then we might sometimes consider switching them from IV to subcutaneous. But there are also some people who experience fatigue on the day of the infusion itself or the day after. So it's not one size fits all. And here I think it's a very important point that discussions between the provider and patient about their specific product, their specific rate, their specific dose is to be looked at. And I would not take this as a general statement, because there are a lot of things that play into the immunoglobulin replacement therapy. But in general, what I told you so far is that fatigue has now been proven in an evidence-based manner that is increased in patients with immunodeficiency, and particularly in CVID. Fatigue affects all ages, so we should not just blanket say that it affects adults, but we should pay attention to it also in children. Fatigue is important and affects the quality of life of individuals. And it has been shown that it's higher in individuals with non-infectious complications. And as I mentioned in the last slide, there have been an association between fatigue and the wear-off effect of immunoglobulin products. So we kind of hypothesized that fatigue is actually the tip of the iceberg, and maybe it's the first symptom of more significant underlying problems like autoimmunity, malignancy, chronic lung disease, GI disease, or having bronchiectasis. And at the bottom of all of this, there is an inflammation. So it could be that fatigue is a clinical symptom of an overly inflammatory process that is not under control. And this is a very simplified hypothesis, if you will, but this is kind of what was going on in the back of our minds when we were doing all of those studies. But all what I shared with you so far is association, which means that you do a study, you find one disease and you find another disease, and they tend to come in together. But you cannot prove for sure that there is a causation. Like you cannot say that A is causing B or B is causing A, but it's just like A and B go together. So there were a lot of studies that if you look in the literature or Google, you'll find a lot of things that are proposed to cause fatigue. But the reality of the matter that there are very, very few studies that can mechanistically prove that something is causing fatigue, particularly in patients with immunodeficiency. But of interest to me is the hypothesis that links the microbiome with fatigue through what we refer to as the gut-brain axis. As you're probably aware, the microbiome means or refers to all the microbes that live in the gut of healthy individuals. And now there are multiple studies, some of them done by us and many by others, that showed that the gut microbiome composition in patients with immunodeficiency, CVID, and other inborn errors of immunity have a different microbiome composition compared to healthy individuals, even if you compare patients with immunodeficiency to their household controls. Why is this significant? Because the microbiome is considered a metabolic order, a metabolic organ. It actually metabolizes our nutrients and helps us process the food and the nutrients that we ingest. So if there are shifts in the microbiome composition that lead to unhealthy microbiome, then we could predict that the metabolic function of this organ is no longer beneficial to the individual. And also having unhealthy bacteria in the gut might cause some local inflammation. And the idea that this causes some impairment in the epithelium of the gut and causes what we refer to sometimes as the leaky gut syndrome. So some of those bacteria or their products might now become available in the bloodstream and passes the blood-brain barrier and causes some symptoms in the brain. And that's kind of the general thought of the gut-brain axis. And there are several studies that looked at it. As I said, all of them are association because proving causation, particularly in microbiome studies, is very, very hard. We looked at patients with fatigue who had cancer in collaboration with the group at MD Anderson Cancer Center in Houston. And we indeed found that the patients who had cancer and had fatigue have a different gut microbiome composition compared to the patients who had similar types of cancers but did not report fatigue. And when you look at different patients in different groups, you might find different bacteria, but the idea is that there are probably some bacteria that function differently in the gut that are associated with fatigue. So now we know that it's prevalent. There are a lot of associations between fatigue and high disease burden, maybe some links to the gut microbiome changes. But perhaps the biggest question on everybody's mind is how can we improve fatigue? And as I go through the remaining part of this presentation, I would say that when we talk about managing fatigue, we talk about three big categories: controlling the contributing factors to fatigue, non-pharmacological interventions, and then pharmacological interventions. And I put them in this order because in reality, controlling the contributing factors might be the most effective, followed by non-pharmacological interventions, and the pharmacological interventions are perhaps the least effective. And I'll walk you through this a little bit. So when we talk about contributing factors, and some of this data is borrowed from cancer. So if a cancer patient has anemia, then treating the anemia is expected to improve their fatigue. If somebody has low thyroid function, then replacing it is expected to make them feel better. If they have low testosterone or hypogonadism, then it's expected that if you replace those hormones, they will start feeling better. Somebody is not able to sleep okay because they have obstructive sleep apnea or just poor sleep hygiene, then improving their sleep might improve their fatigue. Somebody is taking medications that make them excessively drowsy and tired, then adjusting their medication is expected to improve their fatigue. And that's what I mean by contributing factors. And that's usually the most effective intervention. And then we talk a little bit more in the coming slides about the other interventions. So there are some things that have been specifically studied in patients with immunodeficiency. And because we link quality of life and fatigue in the previous studies, I'm going to borrow the literature that showed that there were interventions that improved quality of life in patients with immunodeficiency and inferred that also it might improve fatigue. So many years ago, there was a survey that was sent to clinical immunologists and patients, and they found that patients report improved quality of life if they have access to a clinical immunologist, if they have regular access to their immunoglobulins, and if their GI disease is controlled. And then later on, there was also a study that looked at patients with immunodeficiency and exercise and found that patients who exercise have a better quality of life as well. So based on this, what are the interventions that are more likely to improve fatigue? And as I said, some of those data are borrowed from cancer-related fatigue because it's the type of fatigue that has the best evidence-based data out there in the literature. So exercise, particularly aerobic exercise outdoors, have been consistently shown to be helpful in fatigue, particularly if you couple it with exposure to sunlight. Now, a lot of people feel that this is counterintuitive. When somebody's tired, you're telling them to exercise. But inflammatory fatigue does improve when you exercise. You're just going to have to be persistent. And it has been shown continuously that people who have fatigue and they start exercise sooner and more regularly, their fatigue improved several times more compared to the ones that do not have any physical activity. Improving sleep is very, very important and perhaps underestimated as well. And there were a lot of studies that were done in multiple diseases that show that sleep is perhaps one of the most important factors that contribute to fatigue. And sometimes it's just ignored or underestimated. But we started paying more attention to sleep hygiene, obstructive sleep apnea, going to bed at the same time, waking up at the same time, all contribute significantly to a better sleep hygiene and better outcomes in relation to fatigue. Seeking help, psychological support, and seeking professional help has also been shown to be effective. And finally, there are some medical interventions that have been shown to be effective in several studies. And those studies are specifically borrowed from the cancer literature again. And it goes around the psychostimulants like modafinil or some of the other medications that you probably heard of as used for the ADHD. And the way that we explain it to the patients is like drinking a very big cup of coffee and getting that energy that happens after you drink that big cup of coffee. But the psychostimulants are not effective in every single individual, and usually they are effective in particular individuals. You have to also be careful about the side effects, particularly the cardiac because they can cause tachycardia and increased high blood pressure. Those medications also are better prescribed by psychiatrists and neuropsychiatrists as they require monitoring. And if they don't work, you don't want to continue on those. So you give them usually a trial for about 30 days, and you either find response or not, and then you stop. Vitamin D deficiency is important to look for and replace if they, especially individuals with fatigue. And as I mentioned, exposure to sunlight has been associated with improvement in fatigue. We don't know directly if this is associated with improvement in vitamin D deficiency, but definitely sunlight exposure has been shown to be very effective. There are studies now that showed increased prevalence of hypogonadism in patients with immunodeficiency, particularly CVID. So treatment is important for the quality of life, for the health of the bone, and hopefully with fatigue as well. And I always encourage individuals who experience fatigue to look at other factors like having depression, having anxiety, and getting those treated and formally evaluated and treated is very important. Because as I mentioned earlier, contributing factors play a major role in fatigue. It's not a one cause, and that's why it's not one treatment, but rather trying to attack the problem from multiple angles perhaps would give us better results than trying to just hang our hat on one pill or one injection or one specific treatment. So let's revisit the three concepts that I shared with you earlier. Like other chronic illnesses, fatigue is expected. It's true. Fatigue is more common in patients with immunodeficiency and even other chronic illnesses. The second concept that treating the underlying inborn error of immunity or immunodeficiency should improve fatigue, maybe, but immunodeficiencies are chronic. Many of them are not curable at the moment. So we try our best to control the underlying condition, but it's not automatic that if somebody is taking their immunoglobulins, prophylactic antibiotics, or even their immune suppression, that their fatigue is just going to completely go away. But we definitely believe that controlling whatever underlying conditions is very important to control the disease, quality of life, and fatigue. Finally, the third statement was fatigue is not life-threatening and can be endured and may not need to be treated. I think it's very clear to the audience here, and hopefully as a clinical immunologist, we all came to the same conclusion that fatigue is associated with higher morbidity and mortality. It does impact outcomes in our patients. So we are now doing better job, I hope, in addressing fatigue and trying to intervene to anything that is reversible. We're trying to intervene on to help improve outcomes in patients with immunodeficiency. And I'd like to close by a statement that is really old, but still stands very well by Avicenna, the father of modern medicine, who wrote in his book, The Canon of Medicine, illusion is half sickness, calmness is half of the cure, and patience is the first step of healing. And with that, I'd like to thank all of you for contribution to the Immunodeficiency Foundation survey and for your attention here. And I'd like to acknowledge all my colleagues and collaborators. Thank you so much for your attention.
Thank you so much, Dr. Hajjar.
I will try to stop sharing.
Thank you. Yeah, and thank you so much for that great overview on PI and fatigue. We have a lot of great questions rolling in. So now we do have some time for some Q&A. So if you thought of a question while Dr. Hajjar was presenting that you would like to ask, please enter it in the box on your Zoom screen. There should be a black button that says Q&A, and you can type it in as well. So after our Q&A, please stick around. I will share some information about a few of IDF's resources, as well as our upcoming events that you want to make sure not to miss. All right, so let's get started, Dr. Hajjar. All right, someone is asking that I have been plagued by horrible fatigue and my immunologist and rheumatologist will not listen or take me seriously at all. Do you have any tips on how I can get them both to listen and respond?
I'm sorry that you're going through this. Sometimes when patients come into the clinic and they have complex medical problems and a lot of symptoms and a lot of medical complications, it might be overwhelming to the provider. And sometimes I find it helpful if somebody comes in with a list that is not very lengthy, that is reasonably covered within the time of the visit, and just say, today I would like to discuss those issues. So perhaps one of those visits you could specify and say, this visit is to specifically discuss the fatigue. And you can provide some objective data, like, for example, fatigue has interfered with my ability to do X, Y, and Z. I missed X, Y, and Z because of it. Is there anything that we could do? I think that trying to be as objective as possible and as specific as possible might be helpful. And we all try to help our patients, but sometimes there are a lot of things going on and you're not sure which one to focus on. So maybe if you help direct them, that would be helpful.
Great. Thank you. That's great advice. Someone is asking if their Ig levels remain high and they have no trough with subcutaneous infusions, what would cause marked fatigue the day before and after infusions?
Yes, so that's an important question, and that's why when I mentioned the wear-off effect, I cautioned about that fatigue can be associated with the infusion itself, and fatigue can also be associated with the wear-off effect. And fatigue can also be not relevant, not in correlation with the IgG peak and trough as well. So I would say it's common for all patients to experience some level of fatigue on the day of the infusion, and that depends on whether it's sub-Q or IV and depends on the dose. And for that, hydration is usually very helpful. Most of the patients who report fatigue towards the end of the infusion have an association with their IgG troughing down. And sometimes we do increase the dose for that. If it is not associated in this particular case with low IgG, I'll look at the other factors that I mentioned in the slide and just see if there's anything else contributing to it.
Great. Thank you. As someone with CVID who is engaged in strength training, I have concerns about overextending myself in order to avoid post-exertional malaise. Do you have any recommendations on training or overall exercise for those of us who have CVID?
I usually encourage people to have a personal trainer, at least for the beginning, because that will help you to learn to pace yourself. They will teach you safety measures. They will teach you how to warm up and the warning signs that tell you how to stop, and make sure that you're doing it correctly. Maybe after that you learn it and you can be on your own. But at the beginning, sometimes having a personal trainer is helpful.
Great. Thank you. How do you know if fatigue is causing brain fog or vice versa, or is it completely independent?
Well, I mentioned the cognitive fatigue, which means that sometimes an individual feels unable to perform cognitive function. So that's what we refer to as cognitive fatigue. But brain fog is also something that has been associated with some medications, particularly sedating medications. So in somebody who has fatigue, it's sometimes very hard to dissect. And I would say that I would encourage the physical activities, the sunlight exposure, looking at the medication list to make sure that there is nothing sedating. I'll start from there.
Thank you. You described physiological fatigue from exercise as a buildup of lactic acid and oh, sorry, my screen just jumped. Oh, sorry. I have buildup of lactic acid and depletion of oxygen to muscles. What if this happens outside of intentional participation in exercise? How does one improve this?
This specific condition often happens during exercise unless somebody is going into lactic acidosis as a side effect of medications or liver disease or another condition, and that will be very specific and requires specific workup. So if somebody's lactic acid is high, not after exercise, then they have to have a specialized evaluation of why their lactic acid is going up.
Would they bring that up with someone like yourself, an immunologist, or do they need to see their PCP, or is that a different specialist altogether?
Usually this is PCP, and sometimes it's depending on what is the organ that is involved. So if there is liver disease, then we ask the hepatologist to weigh in. If there is muscle disease, then we ask the rheumatologist to weigh in.
Thank you. With someone with a PI and several comorbidities, can that make treatment and figuring out what is the root cause of fatigue harder to analyze and thus harder to treat accurately?
Yes, I think that's kind of the bottom line of the
Hmm.
whole presentation, is that there is not one cause for it. And that's why I said we attack the problem from multiple corners, because sometimes we don't really know what is causing it. But if each contributing factor is going to improve it by 1% or 5%, we'll take it and just kind of see how much we can go down.
Yeah, those small increments add up. Someone else is asking, I have CVID treated weekly with sub-Q infusions and have fatigue. I also have long COVID symptoms, which have made the fatigue more pronounced. Are there programs that are studying this combination? If so, where can I get more help?
I am aware that the University of Texas in Houston have a chronic fatigue clinic. They do have specific criteria for enrollment, but this is the place that I am aware of in Houston. I'm not aware of places outside Texas, but that's the place that I'm aware of in Houston.
Mhm. Thank you. Someone is wondering what can be done to assist the malabsorption that comes with CVID, resulting in malnutrition and severe fatigue.
Yeah, absolutely. The malnutrition is a very important problem, and this is where we work very closely with our GI colleagues and the nutritionists. So there are some individuals who needed to be on TPN, which means that they get their nutrition through an IV line, at least for some time. But this is something that, this is a general advice, but those are conditions that the individual has to be seen. You have to know exactly what's going on in their gut, why they are not absorbing, what they are not absorbing, what kind of vitamins, and whether they can replace it orally, or they have to go on a bowel rest, or they have to get a G tube, or they have to get a
Mhm.
TPN. So this is GI/nutrition consult for sure.
Okay, thank you. We've had a couple of questions come in related to your mention of the microbiome. While that is not our exact topic for this evening, do you have any resources or next steps regarding that portion of your slide deck that our attendees might be able to explore after today's talk? I know you did a webinar back in the fall on PI and the microbiome. I don't know if you have any other additional resources we can share with everybody after the fact.
I think that the webinar perhaps has the most up-to-date information that, those researchers do not make big changes over a short period of time. So I would refer to that webinar.
Great. All right, our next question is, I have CVID and was recently diagnosed with multiple sclerosis. As a consequence, I have both physical and mental fatigue, as well as dizziness that worsens with physical activity. While I know you can't speak about my specific situation, do you have any insight about what someone's next steps could be with all of these conditions?
Well, I really have not a lot of expertise about multiple sclerosis, but I would definitely defer to neurology about
Mm,
their treatments. I know that physical activity is encouraged as much as can be tolerated. So I would say that through my years of research and clinical practice and training, the two things that I find more effective in advice, although they are not easily taken on, is physical activity and sunlight exposure. Those are the two things that stand true, regardless of what is the cause of the fatigue or the underlying condition. And I'm not saying everybody's gonna run the marathon, but even doing 5 minutes of walking or any kind of physical activity that you can do, and sunlight exposure. So I tell all my patients, if you cannot do anything at all, just sit outside and get exposed to the sun.
mhm.
That has been shown to be effective.
Great, thank you. All right, this next question is a great one. Someone is wondering, how do we know what is normal? What level of fatigue do regular people experience versus the extra fatigue people experience due to a PI?
I would say that this was a point that was brought to me by my own mentor when I was writing my first proposal for this work, and um, I was told, like, I feel fatigued all the time. So why would we care about fatigue? And I think that's why we did the first study and we showed that it's 30% versus individuals reported 3.5%. And I think what draws the line is the ability to perform mere activities. So one time I was in a workshop and I worked with, I was sitting with one of the rheumatology case coordinators. And she told me that what she found to be very useful when she talks to the patients who have fatigue is to tell them, if it's stopping you from doing activities that you like, then that means fatigue. So if somebody says, I feel so tired, I do not want to go to work today, it's different from somebody who loves the opera, for example, and they say, I feel so tired, I cannot go to the opera. So if it's interfering with what is very important to you and you cannot do, then maybe this is when you draw the line and you say, this is not normal.
Mhm. That's good perspective. Thank you. Someone is saying that they are still struggling to understand why those with PI or CVID are more likely to be fatigued. Is it because our bodies have to work harder to fight illness or work harder to absorb our infusions? I still just don't get it.
Right. And I think you're not the only one. I think we all don't get it yet. But there is this concept that inflammation is coming from chemicals that our body is making, and they circulate everywhere, including in our brain. And when those chemicals are produced in larger amounts, our brain perceives feeling tired. And I don't mean to be very technical here, but there were studies that were done on animal models in which they reduce those animals have an immunodeficiency because this is how they were designed. And then when they put them into mazes and things like that, they don't function very well. And for some of them, when they infuse them back with immune cells, they do better. So we do believe that it's probably all the inflammation that is stemming from immunodeficiency that is causing a lot of those chemicals to affect our brain and ability to perceive fatigue.
Mhm. Thank you. Do you have recommendations on managing fatigue well enough in order to participate in exercise? I struggle to even get to the point where I can even participate in an exercise regimen.
Right. And this is where you would start really slow and make baby steps. So if you are not able to join a group because they are way ahead of you, you could maybe say, I'm going to walk for 5 minutes, and you only walk 5 minutes. But then you say, tomorrow, I'm going to walk for 6 minutes, and you only walk for 6 minutes. But then at the end of a month, you might have stretched your 5 minutes to become 30 minutes, and that might get you ready. And I tell my patients, do not get too excited. Do not do 15 minutes because maybe tomorrow you're not going to be able to do it. So add really very small increments, and sometimes having a buddy. So it is much easier to go for a walk or sit outside if you have somebody. So somebody else being with you might be helpful as well.
The buddy system makes it fun. I also want to share, I think it was the end of 2021, we did a three-part forum series called Zebras Fit for Life, where we had a physical therapist come and speak to our community about different ways to adding physical activity into your day-to-day, especially if you have limited mobility or are extremely fatigued. So if you're interested in tuning into that, that can be found on our YouTube channel. I think it was back in 2021. It was called Zebras Fit for Life, and I think it was a really great series to really introduce the topic of very light exercise to our community. So I hope you can check that out and maybe get some ideas from way back when. All right, next question. Someone is wondering if you can share a little bit more about diet and fatigue. What are foods that can be eaten to support reduced fatigue or increase higher energy levels for people with PI?
I mean, I don't think that there are evidence-based diets that say specifically, there are some energy drinks, but I would not particularly recommend them, any specific brand or anything like that. And I'm usually wary of those because sometimes they cause tachycardia. But I would say high protein diet is always helpful because if you eat a lot of sugary food, those are burned very quickly. So if you want to build muscle, you probably want to focus more on protein.
Right. Thank you. All right, this is another great question. Do you have any insight on napping? Is it helpful, hurtful, anything specific to those with PI?
I would say do whatever works for you. If taking a short nap would improve your activity for the rest of the day, by all means, it makes a lot of sense. I think there were some studies a couple of years ago, I think maybe before COVID, that showed that if people, and this is not for anybody with a specific underlying disease, but they showed that if people who work 8 hours take a nap for 30 minutes, their work function after the nap is better. So I would say that if somebody takes a short nap and they wake up more active, by all means, if it's feasible for you, why not?
I know you shared a bit of this data point in your presentation, but someone is wondering if there's any data to show whether weekly or bi-weekly subcutaneous therapy is tied to more or less fatigue.
I really think that it's based on the individual, because the data is a collection of all the patients together, and some of them would have answered differently.
Mm-hmm.
I would say it really depends on the dose, and it depends on the individual as well, because we metabolize the immunoglobulins differently, and individuals who might get an infection might use up their immunoglobulin in that specific week faster
Mm-hmm.
than if they are not having infection. People who have gut disease, they might lose some of their immunoglobulin. So I don't think that I can answer this question in a general way,
Mm-hmm.
except that I say that the more peak and trough, the more that we hypothesize there will be more fatigue.
Kind of along these same lines, someone who is on an IVIG product currently is wondering, would you suggest switching from one IVIG product to another IVIG product, or switch entirely to a sub-Q product? Is there one, like, should you try other IVIG before you switch down to sub-Q, or should you go from just IVIG to sub-Q?
If I have somebody who has clear wear of effect, I usually switch from IV to subcutaneous.
Mm-hmm.
But I don't make big promises that this will make magic, because it doesn't always. There are some people who do, and there are some people who don't, and that's why I suggest it, and we normally have a discussion about all the data that is available, what to expect from IV, what to expect from sub-Q. And some people go on a trial and they like it, and some people say the IV was better for me, and we go back.
Yeah. And I think we've done a couple of webinars or even conference sessions on that, of that your treatment is unique to you. So what works for you might not work for someone else, and it really is a trial and error situation. Great. So someone is now asking, how can we determine if the exercise will help make us more energetic or sicker? This individual loves running, but whenever they do it, they develop pneumonia not too long afterwards.
I'm sorry to hear that. There was a specific paper that done by a group of clinical immunologists not a long time ago, maybe 3 years ago, specifically addressed this question, because there is a concept that sometimes exercise is harmful in individuals with immunodeficiency, and this particular paper showed that there is no evidence of harm. Now, I don't know that there is a direct cause and effect between running and pneumonia, but I would also look at the environment and whether there was an exposure to some infectious. But our thought is that exercise actually stimulates the immune system in a good way, and help decrease the rate of infections in general. But I would look at the environment and look at everything. And as I said, there was one study that specifically, in an evidence-based manner, did not show any increased risk of harm for people when they exercise.
Well, that's good news. Is there any relation to fatigue with B cell or T cell issues?
Yeah, I think that the animal studies that I related to were all T cells with an association of B cells as well. From our human, as you saw, the CVID was the single disease with the most prevalence of fatigue, and many of those patients have normal T cells. But as we know, the CVID is a disease when you don't have immunoglobulins. So I think it's related to both.
Great. This individual has a toddler who was recently diagnosed with complement deficiency and is chronically tired. Do you know if complement deficiencies have a higher rate of fatigue? And what avenue would you first pursue, especially in young children?
I'm afraid I don't have a definitive answer because it's such a rare disorder
Mhm.
that I'm afraid I don't want to give the wrong advice.
No, I understand that. So thank you for sharing, or thank you for saying that. All right. Someone is saying, do you have any information on B12 injections? Have vitamin B12 injections ever been tested for this type of fatigue?
So we never prescribe vitamin B12 for fatigue itself, but we
Mhm.
do look for vitamin B12 deficiency in our patients because there are a lot of individuals who have reasons for what they don't absorb vitamin B12. And if we have a patient who has vitamin B12 deficiency, then vitamin B12 injections would be appropriate because the core problem is the inability to absorb. So giving them oral B12 would not be very sufficient.
Mhm.
So again, I don't use it to treat fatigue, but if it is indicated, some patients do feel better overall because vitamin B12 deficiency can lead to a different type of anemia and some neuropathy. So definitely you don't want to leave B12 deficiency untreated.
Right. All right, our next question is what can be done if medication management and exercise are not helping fatigue and neither is switching to sub-Q? They apologize if this is a repetitive question. They're just hoping to get all the information that they can.
Absolutely. That's why I said that there is no one thing that can be done. And I think that we don't often win the battle of going from 100% fatigue to zero fatigue, but we sometimes look at what is reversible and try to manage. And this is, again, one of the things that I try to push is that don't give up on exercise and sunlight exposure, even if it doesn't seem to be effective at the beginning. The muscles that work are definitely stronger than the muscles that do not work.
Mhm.
And so you want to keep going, even if you don't see a benefit now, at least you're not going backwards.
All right, this is our last question that I have. As I said at the beginning, we tried to kind of lump and batch certain questions that had a similar theme. So if we didn't read your question aloud word for word, we tried to put a lot of them together so that way we didn't inundate Dr. Hajjar. So this question is there a way that people with PI can reduce fatigue accumulation? My fatigue gets worse throughout the work week to the point where I often sleep through my alarm as it gets later and later into the week.
Yeah, I think there are a lot of uh, new thoughts right now is that you have to pace yourself and you have to use up your time wisely. So if you know that there are certain things that bring on the fatigue or your fatigue worsens in a particular time of the day or time of the week, then organize your tasks that the hardest tasks are going to be done in the times of the less fatigue. And you move your schedule to when you know that you're going to have the worst fatigue, then move the tasks that are the easiest to that time. So in other words, kind of like manage, it's like budgeting your time and budgeting your energy.
Mhm. Great. Thank you, Dr. Hajjar. All right, I
You
think that's all the questions we have for now. So I thank you so much to you for answering all of the wonderful questions from our audience and also those in the audience for their participation and their engagement. We are just so appreciative for your time and for everyone tuning in. So thank you so much.
It was my pleasure.
Great.
Have a great night,
You too.
everybody.
Take care. All right, as promised, we do have a few additional resources and events coming up that I wanted to share with everyone. So please make sure you check out our website, www.primaryimmune.org, where you'll find resources, events, support services, and more. Everything is free to access, print, or have mailed to you. We can also help you find an immunologist or a PI specialist in your area with our clinician finder. And if your question was not addressed during the program, maybe you had a question that was off topic, not related to PI and fatigue, you can submit your question to Ask IDF if you visit primary-immune.org/ask-IDF or give us a call at 410-321-6647. A member of our team will connect with you to answer your question or direct you to the appropriate resource. And I know we did get this question in the Q&A, so a recording of tonight's webinar will be published on our YouTube channel. We appreciate your patience because it takes approximately 2 weeks for that upload to be completed. You can also find all of our recorded webinars and educational content on our YouTube channel. I know I mentioned the Zebra Fit for Life webinar, as well as Dr. Hajjar's PI and the microbiome from this past fall. And if you're looking for ways to connect with others who are navigating life with PI, maybe you're looking for a buddy to start exercising with, you might be interested in joining one of our many Get Connected groups. Get Connected groups are free, virtual, and volunteer-led opportunities to connect with others with PI all over the US. We offer a few location-based groups or some nationwide groups. Because these groups meet virtually, you do not have to join one in your area. We encourage participants to join any group, time, day, or leader who works for them. If you're interested in starting a group in your area, please email volunteer@primary-immune.org to learn more. You can see on your screen all the locations we have groups in the US, as well as some other groups that are nationwide, including Adulting with PI, a CVID group, healthcare professionals, so those who work in a healthcare setting. We have 2 groups for parents of children with PI, a partners and spouses group, as well as a young adults group. As you continue to fill your spring calendars, I want to make sure that you save the date for our next 2 IDF webinars. Ask the Expert PI and Autoimmune Conditions on March 21st, and Ask the Expert Travel and PI on April 18th. Those are Thursdays and will begin at 7 p.m. Eastern. I am so excited to share that registration is still open for the 2024 PI Conference, which will be hosted in person at the Sheraton Grand Riverwalk, Chicago from June 20th to 22nd. In addition to 50 educational sessions and connection opportunities, the conference will include the world premiere of our feature-length documentary, Compromised: Life Without Immunity. The early bird registration deadline is March 31st. Visit primary-immune.org/conference to register, view the agenda, watch the documentary trailer, and learn more. Join us for the IDF Walk for PI kickoff as we jump into the 2024 walk season. During this fun-filled hour, we'll share more about what the Walk for PI is, as well as new opportunities and tools to help you and your team. Plus, just by registering and attending this event, you'll be entered to win one of several gift cards. This is an event you don't want to miss, so please use the camera feature on your phone to scan the QR code and register today. We'll also be hosting Walk for PI events across the nation, as well as one virtual walk for those who may not have an in-person location nearby. All locations are at a local zoo, science center, or amusement park, so by registering and attending, you get to experience the remainder of the day having fun with your family and friends. We hope to see you there. We are currently revamping the Walk for PI website, and it will be available and revealed during our Walk for PI kickoff on March 27th. If you've been wanting to make a difference for IDF and the PI community but are not quite sure how, you can complete a do-it-yourself fundraiser. Make a difference and fundraise your way. From gaming to bake sales to workplace fundraising, the possibilities really are endless. You can use your hobby and passion to make an impact on the PI community. Again, use the camera feature on your phone to scan the QR code to learn more. And thank you again to our wonderful sponsors for their generous support of our education and community services programming. And again, thank you to everyone for your participation this evening. And thank you again to Dr. Hajjar, wishing you a healthier day every day. And we look forward to seeing you at one of our many events this spring. Have a great rest of your Rare Disease Day, February 29th, and I hope to see you all again soon. Take care.